Good afternoon, everyone, and thank you for joining us today for this exciting webinar. My name is Andrea Balmer, and I am a research associate at the Swiss Patient Safety Foundation. We're delighted to have you here as part of our Patient Safety Awareness Week 2025, which runs under the slogan, Keeping an Eye on Risks, Child's Play. The goal of this national campaign is to engage, inspire, and empower individuals and organizations to make a positive impact in patient safety. We would like to thank the Swiss Federal Quality Commission for funding the Patient Safety Awareness Week at this point. In today's webinar, we will be exploring the topic of unconscious bias, hidden risk to patient safety. We have prepared an exciting program, and we warmly encourage you to participate actively by asking questions and sharing your thoughts during the discussion at the end of the presentation. Now, before we start with the webinar, I would like to share a few technical notes. For one, please note that the webinar is being recorded. Also, the Swiss Patient Safety Foundation is currently testing the live translation feature of Microsoft Teams. Maybe you already know it. This function allows the spoken audio to be automatically transcribed and translated into the selected language and displayed as subtitles. The aim is to better include healthcare professionals from all language regions of Switzerland, even in smaller events and digital formats. Now, please note that this is a machine-based transcription and translation, so the quality may vary, and occasional technical issues cannot be entirely ruled out. We will evaluate this feature and will kindly ask for your feedback afterwards. A short evaluation form will be sent to you by email. Prior to the webinar, we have sent all registered participants a reminder email containing a link to an instructional video with the short step-by-step guide explaining how to enable the translation feature. The video is available in German, French, and Italian. For those of you who haven't enabled the feature yet, do not worry. We will share the links to the instructions in the webinar chat in just a moment. In addition, I will now give a quick live explanation of how the translation function can be enabled. So, are you ready? We are gonna share the screen for a second. You should now see it. So the first step, click on the More menu displayed as 3 dots in your Teams meeting toolbar. Just like that. Then select Language and Speech. Here on my screen you see Sprache und Sprechen in Deutsch, if you click on that. Then you choose your preferred subtitle language. There you can see what you can choose, the preferred subtitle language. In this case, it would, for example, be English at the top. That's my spoken language now. And then what it should be translated to, so into German in this case, or Italian or French, whatever your preference is. I hope this was helpful. If you have any technical questions, please feel free to use the chat function. For all content-related questions, you can use the Q&A section, which will be reviewed by both me and by our speaker during the discussion part of today's session. Now, let the fun begin. I would like to introduce today's speaker, Ursula Meidert. Ursula Meidert studied sociology and social psychology at the University of Zurich, focusing on health-related topics during her studies. For the past 13 years, she has been working at the Zurich University of Applied Sciences, ZHAW, at the Institute of Public Health in both research and teaching. She is a lecturer in the bachelor program in health promotion and prevention and leads her own research projects on health disparities as well as gender and health. She's pursuing a doctorate on unconscious bias in healthcare and is involved in the project Educational Initiative on Unconscious Bias in Healthcare, which aims to strengthen the integration of this topic into the training of future healthcare professionals. Thank you, Ms. Meidert, for joining us today. And without further ado, I invite you to take the stage.
Thank you for this introduction and welcome, ladies and gentlemen, to this presentation. I'm really happy to speak about the topic and to disseminate the results of my dissertation already before I even finished it. So, hidden risk to patient safety, let's start. I will guide you through this afternoon in my presentation and will first cover what is unconscious bias, what biases are there, what do we know about unconscious bias in healthcare, and why is it relevant to us? And also, what you're probably most interested about, what can we do to mitigate unconscious bias in healthcare? So I have a question for you, and you can already use your chat. Which line is longer, left or right? You can use your chat and take a guess, or maybe you already know the answer. Yes, some of you already know that one. Both lines are exactly the same length. However, the way we perceive them, the left one seems to be longer than the right one. This is just because the way the arrowheads are set. This was an example how unconscious bias can work, as our brain does not always perceive the input as it really is. So our brain makes mistakes in evaluating things, and sometimes they're just like a shortcut. If you have, for example, not enough information, then our brain kind of fills the dots. And in psychology, there is 188 such cognitive biases identified. And this is like a graphic I like to show, which all the 188 are here listed. I give you some examples of those, like the halo or horn effect. I'm sure you have heard about that as well. This is that we infer from known characteristics of a person to unknown. For example, if somebody is sympathetic to us, we might also use this information to evaluate what they're doing, so that if they have a task, we will probably evaluate them better than a person which we have neutral feelings to, or even if a person that we don't like, or the person looks like somebody we don't like. So we take this information from one dimension to another dimension, but even though those two things are not related. Or another one is also the conformity bias. We do and believe things because other people do believe things. This is especially very visible on social media, for example, with vaccination skeptics. A lot of people would, just because they know somebody who says that they think vaccination is bad, also join in this kind of thinking and not believing the evidence there is. So this is just two examples of this 188 described biases. But let me first define bias the way I use it in this presentation. Bias is a term to describe a tendency to favor one group of people over another. And if you look at unconscious bias, this is this kind of beliefs, but it is below the threshold of our perceptions. So I make an example. I might not like dogs, but I might like cats. And if you ask me, do you like dogs? I could say, oh yeah, I like them just as much as cats. So it's below my threshold of knowledge. If I have consciousness about it, could tell you, yeah, I don't like dogs. So with the unconscious bias is I don't know about it, but even though you would maybe approach me with a dog, I might stiffen up, or I might just kind of like try to avoid getting too close to the dog, or just reactions like that. So mostly we can evaluate if people have an unconscious bias, even if they don't know about it themselves. Closely related to this unconscious bias or to this whole topic is also stereotypes. Stereotypes are cognitive generalizations, beliefs, expectations, but also emotions about characteristics and attitudes of members of a specific group. So, for example, you might have a stereotype about Italian people, that they're speaking with their hands, that they eat spaghetti for lunch, and that they also always say "Mamma mia," or I don't know, maybe you have a different stereotype, or that driving in Italy is chaotic or something like that. So mostly these kind of stereotypes are over exaggerated, and they tend to be a little bit more negative than positive. And what's also very peculiar about stereotypes is that even if we meet an Italian person who doesn't speak with their hands, who detests pasta and is a very organized driver, the stereotype still will persist. So stereotypes are very resistant even if we meet people who are contradicting these stereotypes. We can also say that stereotypes are kind of a shortcut. So if we meet people we don't know, we often use stereotypes to categorize them, to basically try to make sense, or to try to deal with the unknown. So what are the effects of unconscious bias, or also stereotypes? Unconscious stereotypes often influence our thoughts without our knowledge. So we don't know that they are affecting us. As I already said, they can help us to categorize things very quickly, and also to deal with overwhelming much information, or also not enough information. They relieve us also from thinking deeply. There was the Nobel Prize winner Daniel Kahneman, who wrote a book about thinking fast and thinking slow. Basically, he said there's two different ways of thinking, and one is quickly. This is kind of the stereotypical thinking where we just make very quick associations, and it relieves us from this deeper analysis, or maybe also spend a lot of time on reflecting on things, which is this thinking slow. However, if we think very fast, or maybe just like in react in the spur of the moment, this thinking is prone to errors. Whereas this deeper thinking, or this slow thinking, usually comes to better results, as we have more time to maybe also reflect on positive aspects, negative effects, threats, or whatsoever. And we also know that this quick thinking happens a lot if we are like overwhelmed, if we are tired, if we don't have the capacity to think a long time, if we are stressed, or also like if we are under the influence of medication or things like that. And also I wrote it can lead to microaggression. So basically we can maybe treat people not the way we should if we are doing this quick thinking. So what are the mechanisms at work in healthcare? Healthcare professionals seem to apply stereotypes to patients, especially in these situations where they are under stress, don't have time, or even multitasking or something like that. So if they don't have time to really take a good thought about what they're supposed to do or what decisions they're supposed to come to. And this kind of judgment often happens about superficial things on patients. And I'm going through a list of things that can trigger this kind of thinking just in a moment. They derive expectations from this kind of characteristics, for example, gender or age or also appearance. And this expectation in turn also influences the way the communication is going with the patient. What kind of recommendations the health professional will make, or maybe also prescriptions. The patient in turn kind of gets a whiff of this unconscious bias. Even if it's not addressed directly, patients often pick up on such a bias, as studies show, and in turn, they don't trust the doctors or health professionals as much as they would if the person didn't have an unconscious bias. And they're also less adherent to the recommendations they're getting from the doctors. So unconscious bias can translate in this kind of expectations or also in communication situations and has consequences for patients. I'm going into that some more in depth. I put here together some results from different studies that show you what this effect of unconscious bias can be in a healthcare setting. So doctors take less time for people with dark skin color, ask less questions, show more verbal dominance, and also make less eye contact, as studies show. These are both studies were conducted in the US, but I also brought some studies which were conducted in Europe. The next one was with dentists in Italy. They became x-rays of a tooth that was borderline restorable. And if the patient was described as a black person, they would tend to say, yeah, the tooth cannot be saved, it should be retracted or pulled out. And if the tooth belonged to a white person, they recommended to keep the tooth and try to save it. So we see that the skin color here was leading to different recommendations what should be done with these tools. Then we have a study with nurses. They were more likely to assess back pain to psychological causes when the patient was described as female instead of described as male. This was a study from Portugal. And we also see that prescribing pain medicine is different between female and male patients, also with exactly the same case, just the gender was swapped. And I know, excuse me, that was not the gender, that was the skin color. So if the patient was described as black, they would recommend maybe a lower doses than when the person was described as white. We see also that patients with foreign names are more likely to be prescribed medication than other types of therapy, for example, physical therapy, just with a foreign name or a local name. This was a study made in Belgium. And we also see that patients with a low socioeconomic status tend to receive less care and also less priority in referrals. This was a study conducted in Scandinavia. So we see that this kind of possible triggers, such as how a person is dressed or the bodily appearance, like is it male, female, is the person tall, or is the person overweight, names, foreign names or Swiss names or familiar or unfamiliar names, Also authority. Does the person have a title, an academic title or a position? Is the person famous or even related to a famous person? Also, place of residence can play a role. Like, is the person living in a place we know that usually which is affluent people living, or is it more like a Putia Langstrasse, which is in Zurich, used to be the place where you really didn't want to raise your kids. Also vocal expressions. We see that people who maybe don't speak the local dialect or the language very well are treated differently than people speaking the local dialect, or are very may also appear very health literate, for example. Then disabilities also, maybe sometimes if people have disabilities, people perceive them as dumber or not understanding as well, even if their disability has nothing to do with their cognitive ability. Also, diagnoses have shown to trigger unconscious bias, especially things like HIV, schizophrenia, or certain type of cancer, for example, cervical cancer. So these are possible triggers which may health professionals sorry, I have to start again this sentence. So these are triggers that health professionals actually can pick up and make the whole interaction with the patient kind of under this spell, I would almost call it. I'm quickly going to explain you how we measure unconscious bias. I made this example with the dog, which may maybe stiffen up, and also in videos, if a conversation is videotaped, we can count the eye contact or also verbal dominance in a conversation. However, if we don't have a tool of video, we use either a reaction time task or a vignette. A reaction time task is a task where associations are measured. And I'm going to describe one. There's several similar tests. They all use time as a measure for you to sort pictures to words. For example, if I see a picture of a Black person, I have to sort it with positively connotated words such as happiness, love, sunshine, just things like you would perceive as good. And a picture of a white person, which is associated in this example with badly connotated words, for example, war, loss, unhappiness, things like that. And then you would have to sort these words, and then it's switched. So in the second part of this test, you would have to sort bad words to Black people and good words to white people. It's always measured how fast you are and how many mistakes you're doing with sorting this sorting task. And then it is measured how much faster you are, for example, to sort good words to Black people or the other way around. This is called the implicit association test, and you can take one. It's for free on the internet, and it's not only with skin colors, it's also with people who are overweight, with gender, or with many other aspects of unconscious bias. The other way to measure unconscious bias is with vignette studies. In a vignette, we usually describe a case or a situation, and you have to take a decision. So I'm going to show you shortly a vignette I use for my students in my study. For example, you would...
Hast du da unten jetzt mal versucht zu wechseln?
Okay. Okay, I continue. So basically what you would change in a vignette, like maybe the age of the person or maybe the gender of the person, and therefore manipulate if you would treat the person the same, depending on the gender or the age or whatever. So this is the two most common forms to measure unconscious bias. As a first study in my thesis, I did a scoping review, which is a literature review that not only looks at what is published, but also to find gaps in what is not published so far. I covered the last 10 years since the last bigger review, which was done also by a Swiss team by Fitzgerald and Hurst from a University of Geneva. And in this duration of 10 years, I found 87 records, articles on unconscious bias, which covered nearly 60,000 health professionals. In this studies, 97 biases were assessed, mostly using either EIT or this kind of vignette measure. And here I brought you an overview which kind of biases were assessed more often and which less often. And we see most studies were done, or like at least half of the studies were done on race. And mostly on Black people compared to white people, but also other minorities, for example, Latino people or Native Americans. And I already said it, the reason why we have so much on race is because most studies are from the US. I will just show you in the next slide. However, we also have studies assessing gender bias, weight bias, socioeconomic status, and disability, mental illness compared to physical illness, and also age, ageism, LGBTQI topics such as homosexuality, and also diagnosis. Most often this is, for example, cervical cancer or HIV or schizophrenia have been assessed quite often. This is the regions where those studies were conducted, and you see that almost 3/4 of the studies published the last 10 years were from the US. The US has, for 2 decades now, studied this phenomenon quite to a larger extent as the rest of the world, I would say. And in Europe, we have, I found 13 studies, and there the picture is quite, how should I say? We have like no good picture so far because there's like almost out of every country one study, but no like 2 or 3 studies from one country. So we have study from France, from Belgium, from Denmark, from Sweden, and from Switzerland or Italy. And they have been just about done on every bias there is, on weight bias, on socioeconomic status, on migrant status, on gender. So it's very difficult to get a picture in Europe how the things are there. And this is the professions who have been assessed. Previous literature reviews showed were like only conducted on medical doctors and nurses. And my scoping review, I wanted to see also how other health professions were assessed. And you can see there is very little studies on other health professions. For example, midwife or occupational therapy and so on. So we have very little evidence there how these professions are with this topic. There are some more findings. I found in 70 studies some kind of unconscious bias, and I say some kind of bias because often they measured more than one, and also they use different instruments to assess bias. So in one instrument maybe it showed up and in another not. So it was sometimes also there a little bit difficult to get a picture. Is there a bias that really persists, or is it also would this even translate into practice? In 2 studies, they found a conscious bias against a majority, against white people compared to Black people. This was in relation with drug abuse. 11 studies found no bias, and yeah, We also find more bias in reaction time tasks than in vignettes. So this is why I also thought it's not always clear if a bias really translates into an action. So I might have a bias, but I still might be able to treat my patients the same or come to the same evaluations. So yeah, I will be happy to discuss this with you later. Also, there were studies which showed interventions, and some interventions were described to reduce unconscious bias, were like empathy building or exchanging information in real time. So it showed, for example, that in a situation where not enough information is of a patient and where unconscious bias is prone, if health professionals can shortly talk about the case, they will come to much better result as if the person is not able to exchange information. In my second study, I thought I would like to see, to contribute to the lack of knowledge in Switzerland, and I did an online survey with students of health professions at the ZHAW, and I included a whole all health professions we have of all levels. So there was about 2,100 students, and I used a vignette and a EIT. For the vignette, I show you an example. I used Mr. or Mrs. Hafner, or also a Tamilian name. I had a different age range, and I described the patient as living in the region, works. I put a work which is more affluent, and a work which will be, the salary will be much less, to symbolize the socioeconomic status. And also changed whether the person was mentally ill or had a physical illness. So I tried to assess not one bias, but as much as possible to see whether some bias would show up in my students. Another thought of mine, which I wanted to test, was I was not sure how bias is formed. Are just everybody has biases, right? But do they, health professionals, have those biases and they keep them until they're retired or change to another profession? Or is it that unconscious bias is built, for example, through education, because we show always the kind of same examples in class? Or would students pick up from other health professionals the way they treat maybe minorities, that they also build unconsciously this unconscious bias? So that was my question in the background, which I tried to test. Also, I had them make a EIT on homosexuality, and I show you here how this would look like. It's basically this kind of little figures, or also words which would symbolize homosexuality or heterosexuality, and students would have to do this sorting with good words or bad connotated words as fast as they can, and then see if they would have a bias. So, oops, I'm too fast. So, in my study, I could not find any kind of bias. I could not find one in the vignettes, and I also could not find one with the EIT. This was honestly very surprising. As you saw before, almost all studies showed a bias, and I thought my students probably will fit in this category as well, but we couldn't find one. And it's also showed that the explicit attitudes, when we ask them, how do you feel about elderly people or young people or homosexual people or heterosexual people, they would in tendency favor minorities or vulnerable groups. So they would tend to do the opposite as expected. So they would tend to favor poor people, migrants, women, and so on. So this might be good news. Also, I would like to discuss this later with you, that our students are just very open-minded and don't have a bias. But it also could mean that maybe my instrument wasn't good enough, or with the vignette, I tried to ask for too many vignettes at the same time. I don't know. What I also looked at in my analysis was that if there was a difference between study program, because my thinking was if they learn it in class, then there will be a difference maybe between nursing and physical therapy. However, I did not find any difference between study programs. I also could find no difference between the years the students were in. So it was not like in the first semester they have no bias and in the fifth semester they have a bias, or the other way around. It was absolutely no difference. And also work experience had no influence on that. And also age and gender did not have any influence on that result. My third study was from the same online survey. I asked students, have you ever observed health professionals treating patients in a demeaning or discriminatory way? This was to test my hypothesis if they pick unconscious bias up by observing, if they would like go into practice, be relatively unbiased, and then maybe see how health professionals would treat minorities or vulnerable groups differently. And the idea was if they would, maybe that it would show also in their bias. I can tell you it did not. However, I used these answers to do a qualitative analysis, and it showed that 50% of students have observed this kind of treatment. 30% of students were not sure what they saw. They said like, yeah, I'm not sure if that what I observed was bias or not. And 20% said, no, I haven't done this kind of observations. And those students were most likely from the first or second semester, which they don't have much experience or not at all, depending on the course they take. So the analysis showed that most common discriminatory behavior was a deliberate withholding of care or medication. For example, pain medication was not given or was given with delay, or maybe people were left in their wet clothes when they peed themselves, just things like that. This was followed by verbal abuse, like discriminatory remarks or rude remarks, things like that. And also ignoring patients, maybe just not look at them or ignoring their calls or things like that. Then also we had some little but also more severe cases where they described physical abuse. So basically patients were treated very roughly, or they were made to do things they didn't want to do. The students also described what their perceived reason was for that kind of treatment. And it was most likely that the patient was foreign nationality or could not speak German very well. This was followed by diagnoses. People with addictions are often treated worse than people with other illnesses. And gender and socioeconomic status was also a perceived reason to treat patients less equally. So now I would like to zoom out again. I zoomed in on my results and on my students from the ZHAW. I also briefly looked what other research results there are from Switzerland to give you a kind of a view, where do we stand with this topic in Switzerland. There is a study from Lausanne with medical students, which were asked, did you ever observe gender bias in your course of studies or a practica? And about 68 students reflected on that, basically describing situations as biases in teaching, but also in anamnesis, physical exam, differential diagnosis, or also the final management of the patient. So they could observe that and brought examples they described. Then we have a study from Zurich, Canton of Zurich, where general practitioners were asked with this kind of vignette whether they would treat a patient immediately or not at all, or maybe later on, depending on the person's ethnicity or also their status, if they were what kind of status they had, resident status in Switzerland, or also economic position. And the physician's willingness to treat a patient was foreigner or was poorer was less than a Swiss person. Then we have a study from Geneva with 133 internists and psychiatrists. And there, these two professions were significantly different in terms of unconscious and conscious bias against mentally ill patients, which could be a hint towards maybe they have a different education, and with education we actually can work against unconscious bias. Or the other hypothesis is it also could be a selection bias, that we have people who are interested in this kind of diagnosis and people with mental illness choose to become psychiatrists more likely than internists. So here it is not quite clear, but it's kind of interesting that there are such huge differences. Then in a last study that was done with medical coding, it showed that age and gender had some impact, the way medical cases were coded. However, the findings were not consistent. So not in every case it was gender and gender or age bias there. In some cases not, in others there was, and it was not clear why in some cases it showed up and some not. So this is kind of all the studies I could find from Switzerland concerning unconscious bias. We see that there are probably most likely biases. However, there is only local results there, and also not over all health professions. Now, I would like to come to speak about how to mitigate unconscious bias. In my view, it is important that we start at the institutional level, that there is a clear policy in the institution to speak about equality, equal treatment of all patients, and that there should be a culture established where we people are sensitized about it, or that clear statement that we are in support for equality. And also there should be a speak up culture, so that people actually can speak about mistakes or things they're uncertain about or things they're observed, not to basically have the finger pointed at certain people or not, but to really look at what can we improve, what can we learn about things that didn't go well, or why was this patient treated this way, what do we need to change to improve. Because usually this pick up culture also is not only good for quality and patients, but also for the people working there, if they feel they can speak about it and point out things and work on improving the way people work together. Then also quality control, like for example patient surveys, that there is a control on the outcome, not just asking patients directly, maybe like how was your stay with us, or are you satisfied, but also see like how was the adherence of the patient? Did he? Is there differences on how well it turned out? As I already said in the study before, that the patients pick up on unconscious bias and also might distrust the health professional and not adhere to their treatment. Also, good working conditions. It's maybe funny that I talk about this here, but as we know that stress and time pressure leads to unconscious bias or leads to decisions that are based on unconscious bias. If there is time or environments with not so stressful will really help also to improve the quality and improve the decisions made. Then at the group level or team level, we kind of have the same things like cultivate a speak-up culture, cultivate that there are maybe also reflections on cases where things didn't turn out well. And also have discussions, maybe make it very easy to discuss things or to give advice, or especially for people who may be insecure about a certain patient. I also put evaluators' assessment should remain independent. This is because we see that when health professionals see a diagnosis another person already did, they tend to come to the same conclusion, even if the symptoms don't fit. This is just because they have this conformity bias, that they have this in mind, oh, it's this illness, and then put the symptoms that fit to that and would ignore the other symptoms, for example, that don't fit. So if you always can, maybe also in case presentations or important decisions, maybe also for hiring staff or so, if you could blind names or also not show pictures or show pictures where you don't see the skin color or not the gender, then it might help to basically filter out this kind of gender or bias you have against foreigners or whatever. If this is possible, of course, it's not always possible. Then on a personal level, there's several strategies. One is that maybe you take yourself a EIT, such kind of a test, and see, am I biased? It's important to know that we all have biases. It's also something that one doesn't need to be ashamed of. It's just important that we know that we are prone to mistakes and that we kind of know what those could be. So whenever we tend to need to make a decision, that we take this into account, that we think, oh, okay, I might be biased. Maybe I just ask a colleague again, or I spend some more time on this case to think about it and maybe also reflect on my thoughts about it. The slow thinking is a strategy, and also I before mentioned things like perspective taking. Like if I try to see the world out of the eyes of my patient, maybe I understand better the needs or the patient set, and I can better understand the patient and also make better decisions. Also, a recommendation is to break down complex decision into steps. So maybe go stepwise in the decision, then to try to do all at once in one big decision. And what is also good, to give reason why you came to this conclusion. For example, if you have to explain to somebody why you think it's this and not that, then you would use this slow thinking and also come to better solutions than with this fast thinking, where you just have a hint of how it could be and decide on that. What is also a good technique is this devil's advocate. So if you try to see the negative thing, or try to see the flaw in your thinking or in your decision, and if you can rule it out, it's even better. But to take the on purpose the opposite viewpoint as you have might help to come better decisions. What do we have still on a personal level? Also, replacing stereotypes is one technique. For example, for many people, Black people tend to have the picture of maybe less educated, poor people, also kind of lazy people. This kind of the stereotype Americans would often describe about having Black people. So a counter stereotype is, for example, to look at Barack Obama. So he's one of the most successful Black person, and he was president. He's very educated. He's very well spoken. I would say better than the person in charge right now. So if you use these counter examples, that would kind of replace stereotypes. Even they're very I should say, stubborn to be replaced. So this is one technique you could use. Also, individuation is another technique. This is trying to get your patient to know the patient not as a category, for example, young female, but more like, what is this person like? Does this person maybe have the same hobbies, and see the individual and not the category of the person. So I also would like to recommend some further resources if you think, oh yeah, this topic really speaks to me. There is some books I can recommend. One I already talked about. This is Daniel Kahneman's book, Thinking Fast and Thinking Slow. It's also translated in German. There is also podcasts I can highly recommend if you're more the person of listening, not reading. And also learning materials. There is a self-study tool from the University of Constance, which will show you about unconscious bias in some more details on about 1.5 or 2 hours. And a study tool from Stanford School of Medicine, which is specifically made for a medical context. So now it's time for questions and discussion.
Thank you so much for this interesting presentation. Your inputs really make one think about the actions in daily healthcare practice. And I'm sure the audience also has many thoughts and many questions. So let's start. Just generally, if you do have a question, please post it in the F&A chat, not in the normal chat, so that we can see it. I'll just start off with a first question. How can bias awareness be built into quality improvement or patient safety initiatives? What are your experiences in that?
My experience, I don't have any field experience, but the literature says like sensitization, like also like speak about it, make people aware that there are biases, that this is happening, that everybody has one, and also to not make people fear to speak about it, because a lot of people think, oh, I have a bias, oh my God, and they don't want to talk about it. You have to take the fear away. This is say, okay, it's normal that we have one, but we have a choice. We don't need to act on it. So I think that's one important step. And the other is, yeah, do quality assessments with patients. Like I'm sure like a lot of these patients that in situations my students described would be able to tell you, yeah, I was not treated in a fair way, or I was not treated in a good way, or I was made to wait for my medication. Yeah.
So patient engagement is a very important topic.
Yes, I think so. Yes.
Yeah. Mm-hmm. And you gave a lot of input on how professionals, teams, and institutions can mitigate unconscious bias. But what about patients themselves? Can patients themselves play a role in reducing the impact of unconscious bias? For example, through feedback, as you said, or advocacy, what can they do?
Mm-hmm. For one, also patients also have unconscious biases. So there is also a literature that patients react to health professionals, of course. So what can they do if they perceive the situation is kind of underlined with maybe some bias? I think they could try to just to ask questions, to try to steer. What often happens is they feel that maybe the person, the health professional, is not looking them in the eye, and they kind of get a hint on that. So they maybe would not speak up and maybe not ask questions, and just would become the victim of the situation. So if they maybe would try to break up this dynamic, maybe with trying to make a joke, or also ask. I have a friend who once had an operation and pain and anyway, she perceived that she was not treated like a man would have been treated, and she asked her doctor when she saw me and said, "Would you have reacted the same if I would have been a man?" And he stopped and said, "I would have treated you differently." Mm-hmm. So the doctor could actually reflect on that and say, yes, I would have taken your pain much more serious. Mm-hmm. So maybe also speaking up about things could help. Mm-hmm. There as well, it helps if the person you speak to is not doesn't feel threatened. If you really have a conversation about it and not an accusation.
Mm-hmm. Sounds like a shock for a doctor to hear a question like that at the start, but I think probably a shock that's needed to become aware of their own unconscious bias.
Yeah, I mean, we all don't like to be confronted with our errors, but we need to improve.
Yeah, absolutely. Maybe we can go on to a question from the audience. As you said, patients also have unconscious bias. In your studies, was the clinician's own race or gender also considered in the data? How is that handled in the research?
Yes, those interactions I told you about, the eye contact, this was done with called race concordant pairs and discordant pairs. So, for example, if the person was, the doctor was white and the patient was white, this is concordant. And discordant is like, for example, if the doctor would be white and the patient black. And if it's concordant, then you don't have a racial bias. If it's not, then the bias might be at play. So this is taken into account in these studies. Yeah, this is also why it's recommended that you have a diverse population of healthcare professionals. So the thinking is, if the healthcare providers are more diverse in a sense of race, age, gender, and all that, then this kind of bias is not as much as you have only like one sort of people, like, for example, as it used to be, white male doctors.
Mm-hmm. Okay, so you talked about having different professions in healthcare. Going on to another question from the audience, do you also have other reference populations that maybe don't come from the healthcare sector?
Oh, yes. There's a lot of research also, like in the justice system, where it's basically look how in the police force, like who is shot at and who not. Also, further up this path, also how judges do the judgments based on, for example, skin color, or maybe also affluency, if the person is rich or poor. Yes, there is more literature on that also in the field of schools, basically school grades, who is getting better grades. There's also a lot of gender and also race bias at play. So, for example, I try to have not have my students their name on the paper they hand in, so that I don't have the bias, because I know some of the students, and of course the good ones, you know, and the very bad ones, you know. And so I try to, if I correct their work, I try to not look at the names, so I would not be prejudiced on their homework.
Interesting. So it really goes into all of aspects of our lives.
Yes.
So the methods you apply, one of them at least, has a lot to do with reaction time. One person of our audience is asking, can we assume that this varies over human generations and maybe also education?
Yes.
And how is that like dealt with in research?
There is some proof that it changes between generations. It tends to become less. And also, this is now research from the US. And in the US, when we look at the history, of course, we have this big division between skin colors, from people from slavery with no rights to white people who have the rights. And this kind of integration and giving the rights and being an equal society takes generation to generation. So the EIT shows that some generations ago that they have more unconscious bias than the generation now. So I think that there can be improvements just by the way society is changing. And what was the second part of your question?
I think the education was also asked. How does education affect unconscious bias?
I think in
or
healthcare,
the reaction time, at least in your studies. Sorry.
And reaction time, I'm actually not sure. I don't know if there has been a study conducted, but I know that you also can deliberately fake your test. So if you do it very slow, then you will have less bias than when you do it very fast. So there might be some strategy behind it as well. And I'm not sure whether this has been ever tested on the degree of education. But generally speaking, I think in healthcare, we reflect often on our how we do things, why we do it. And I think this reflexivity process helps us to get to know us better. And it helps to basically against this kind of fast and impulsive thinking. So I think education helps, yeah.
That's interesting. Someone posted in our chat that at the Freiburg University of Health Sciences, they're developing a tool called the EXE-Learn, I hope I said that right, and a platform that uses eye tracking glasses in simulation to enable students to analyze their videos in order to improve their clinical reasoning and metacognition. That's an interesting approach. Are you familiar with approaches like that?
This is new to me, but what I've heard, there's also virtual realities. Just like the vignette I described, they would have a virtual reality with a patient, one time maybe being white, one time black, and then see like how you react. So you can basically train the interaction much better with this kind of virtual reality. There is also a tool on gender bias that the University of Lausanne created together with the University of Basel on gender bias, basically for medical students, which will go through a case and then will always get feedback on the decisions they take. So also there to be better aware of this kind of shortcuts or maybe assumptions you do just by maybe statistical reasons that you look for this kind of diagnosis in this person or not in the other, something like that, to be more aware of this kind of traps somebody can fall in.
Amazing that such tools are coming up. Digitalization is here a very helpful tool.
Yes.
We are already over time. I would like to give you the opportunity, Ms. Meidert, to also maybe ask a question to the audience, or if you have anything else you would like to add, and then we would slowly end this webinar. Is there something you would like to add, or a summarization of your key notes?
From my side, thank you very much for listening and to basically spread the topic into practice.
Perfect. Thank you so much. So We have now come to the end of today's webinar, Unconscious Bias, Hidden Risks to Patient Safety. On behalf of the Swiss Patient Safety Foundation, I would like to sincerely thank our speaker, Ursula Meidert, for sharing such valuable insights with us today. Your reflections have given us an important perspective on how unconscious bias can influence patient safety and what we can do to address it in our daily practice. A warm thank you also goes to all of you, our participants, for taking the time to join us and for your engagement with this crucial topic. We hope today's session has inspired you to reflect further and to carry some of these ideas back into your own work. Before we close, just a few short notes. This session is part of the Patient Safety Awareness Week 2025. We warmly invite you to join the next 3 webinars taking place this week. Running tomorrow on Wednesday, language barriers in healthcare can have serious consequences. Our free webinar, The Risk of Language Barriers, How to Ensure Safe Communication in Healthcare. Tomorrow it explores how to overcome them. 3 experts will share insights on interpreting services, image-based apps, and translation tools, followed by a discussion of their possibilities and limitations. The day after tomorrow, so on Thursday, you can join Professor Dr. Christoph Berger for clinical insights on pediatric drug dosing in his lecture, Efficacy and Safety in Drug Dosing for Children, an interdisciplinary panel with then discussion board dosing challenges in perinatal and palliative care. And on Friday, Anne Röhle will introduce gender-sensitive medicine, showing how considering biological and sociocultural factors benefits everyone by improving healthcare quality and patient safety. Also, don't forget to watch the video lecture, Improving the Healthcare System Through Improved Care for Patients with Sepsis by Professor Dr. Luren Schlappach, that is available on our website. In addition to the webinars, we have created a quiz series consisting of several short online quizzes on a variety of topics. We invite you to take part and to share the quizzes with your colleagues and team members. The more the merrier. Secondly, you will receive a brief evaluation form by email after the webinar. We kindly ask you to take a few minutes to share your feedback with us, especially if you made use of the live subtitling with translation function. And finally, a recording of this webinar will be uploaded to our website, so you can rewatch or share it with colleagues. And with that, we will close today's webinar. Thank you once again, and we wish you a successful Patient Safety Awareness Week. Have a nice day and goodbye.